before you disappear.
Okay, up next we have Prof. Helen Nadel again. She will be speaking to a topic titled Neuroblastoma, out with the old, in with the new.
I hope I'm mic'd up. Thank you again to the organizers and to NTP for sponsoring my visit here, and to all of you for being here. So I'm going to talk about neuroblastoma. These are my disclosures, and these were my objectives when I sent this in a while ago. I was going to describe patterns of neuroblastoma on hybrid imaging, but I think most of you know what neuroblastoma is. So I'm going to show you some interesting things that I have seen, and I'm going to do something a little different than my usual rapid case-based presentations that I usually give. I'm going to be a little bit less didactic and a little more, I guess, innovative of what's coming up. I am going to talk a little bit about theranostic propositions, that we have options, and I'm going to tell you a little bit about a global initiative related to neuroblastoma. So I'll start with what we know now. Neuroblastoma is an embryonal cancer. Median age of diagnosis is 17 months, a disease of the post-ganglion sympathetic system, and tumors arise all over, neck, chest, abdomen, or pelvis. And 8 children per million per year under 15 years of age are diagnosed yearly. And it's the most common extracranial solid tumor of childhood. More than 95% of these cases are diagnosed under 10, and more than 50% under the age of 3. It's the third leading cause of childhood cancer mortality. So what are the clinical presentations? Well, these are from one of my clinical colleagues from Vancouver that show you that you can present with a paraspinal tumor, so-called Horner's syndrome, bulging eye. You can have tumors that relate to the pancreas, adrenal glands. It can be in the liver. Of course, it's in bone, and it can be, as I said, in the adrenal gland. They can be bilateral, and tumors are mainly related to the adrenal area, but they're often extraadrenal as well as the primary site. There have been several recent publications, and I'm going to go through these slides quite quickly to try to gain us back some time, but I have a much longer presentation, and Komozo knows everybody knows how to find me, but my email's at the beginning, at the end, and you can always find me during these days. I'm happy to give you these slides. So there have been several guidelines that came out, published both from major societies. And there was recently a series of white papers published in Pediatric Blood and Cancer, that 25 manuscripts talking about imaging guidelines for all solid tumors. And I would direct you to those. Those are open source and free to everybody. So what do we do for neuroblastoma imaging? Well, in our sphere, we are doing mainly I-123, MIBG, SPECT, CT imaging, and whole body imaging. And we use it for staging, restaging, metastatic workup, response assessment, biopsy site planning, end of therapy baseline, and confirmation of discrepant findings on other studies, such as both other anatomic and other molecular studies. And originally, when some articles came out, maybe more than 10 years ago, it was thought that MIBG was best for stage 3 and 4 disease. I am specifically going to talk about I-123 and not I-131. And I'm sorry if you still have to use I-131, but mainly most people, how many people are using I-131 for imaging MIBG? Nobody, good. All right, I'll go on, I'll move on. Okay, so there are only a couple things I want to say about what a normal scan looks like. We all know about what the interfering drugs are. say a couple of things. Which collimator should we use? Well, I've highlighted there. We should use a medium energy collimator for the 3% high energy gamma. Many people still use a low energy, high resolution collimator, but there have been several publications within the last few years that have talked about using a medium energy collimator. I think is particularly important. The second thing that's important is, and I've already said this, we don't do regional scans. We do whole body imaging. And in neuroblastoma, it's very important to add lateral skull views because on whole body, we cannot adequately discern lesions at the base of the skull. So even on planar imaging, I always get lateral skull views. Now, one other thing that I've changed in my SPECT-CT imaging for neuroblastoma is I've started in the last 2 years to image, doesn't matter where the primer is, I go from the top of the head to the pelvis. Now, some people are actually doing total body imaging. Remember, we've injected the radio tracer. It's not about how many pictures we take. It might be about the CT, but I'm not going to get into that debate right now. That's for another debate. But I am doing SPECT-CT from the top of the head to the symphysis pubis. And that's because, again, there have been several times where I wondered about something at the base of the skull that was undetected on other modalities. The patient had no symptoms, and it turned out that they had base of skull disease in bone, which we couldn't see on planar imaging. So it not only upstaged them, it increased their Curie score as well, most likely. And talking about the scoring system, there are two basic scoring systems which have been devised by European group, the COPEN score, and then the North American group, which is a Curie score. I'm not going to go into that, but these basically score the bony lesions for both systems. COPEN does not score the soft tissue disease, but COG Curie score does score the soft tissue disease. And there are guidelines to how many lesions count in which each part of the score for each region. But these scores are all based on planar imaging. And this is old school. So this is in the part where I've told you what we do now, what we know now. So let's look at some old techniques with new applications. I'm going to go quickly on this. So one of the stages of neuroblastoma is called stage 4S for special, or in the new image-directed guidelines for staging neuroblastoma, it's called MS, or metastatic special. These are infants that are less than 18 months of age who have disease localized to a primary tumor and disease dissemination, but it's limited to the liver, skin, or bone marrow with less than 10% involvement, but it does not involve bone. Key thing is you've got to figure out by however you're going to do it, that it does not involve bone. So-called blueberry muffin baby. These have a 2-year overall survival of almost 100%, 97%, and they do well. Now, they do get treated, but they do well. And so this is this information, I think this article was published in 2009. But what's new, and this is what the MIBG scan might look like. Patient here on the left had a huge liver, had skin disease, had no bone disease. The liver showed patchy uptake. It was a crummy scan, I will admit. And then they got better. The liver got smaller. There was still no bone disease. I'm only showing you regional scan. But then there was this child, 12-month-old male infant, who presented. It looks like they have disease in the liver. We can see many bones all over the body that look involved. And there's funny things over the thighs. A little more SPECT-CT, not in bone. Those are all soft tissue lesions. So quite recently, there was a publication in 2022 about the fact that skeletal muscle uptake in neuroblastoma on MIBG scintigraphy is probably related to this special category, MS, regardless of age, and they have a much better prognosis. So the clinicians are stopping the discussion about overall survival in neuroblastoma. They're actually looking at progression-free survival, and their therapies are now directed to progression-free survival for a certain period of time. If they can get them over the hump of this episode of disease, they live. When the next episode comes, they'll treat that as well. So they're directing their therapies to current progression-free, not overall survival. What else are we doing? Well, there are several places. As you know, adults are doing dosimetry and everything. How many people here are doing dosimetry? I assume everybody's hand's going to go up. Not in pediatrics, just dosimetry. Oh, a few hands went up. How many people are doing dosimetry for any pediatric studies? Note my hand didn't go up. Yeah, so it's pretty hard to do, and we're not doing it yet. But there are some places that are doing it, and Memorial Sloan Kettering is particularly doing it at MIBG, and they found that they could increase their therapy dose as a repeat dose to a child needing repeat therapy. Again, the concept of treat the current disease status today and don't worry about what'll happen totally in the future. Treat that episode as it comes up. And so they could with dosimetry, determine that they had not reached the lethal dose or toxic dose for the kidneys. Other places are looking to use FDG and treat with lutetium. They're looking to change from FDG to dotatate for imaging and then treat with lutetium. This is Cincinnati Children's Hospital, case with multiple lesions throughout the body, and then similar distribution on the dotatate scan. And this was the patient post-luta therapy showing some improvement. So what about an old technique and a new technique? Well, you actually sort of saw this quickly in the last time I had my slides up. This actually is from Copenhagen, from Lisa Borgwart. This is actually on a total body PET-CT scanner. It's using MFBG, and the comparison on the right is a MIBG scan. And you can see that lesions, actually the next, oh, I didn't put it in. I actually showed it before, but we'll move that. It's not going backwards. So the lesion that was in the spinal canal did not show up on MIBG, but did show up on MFBG. Thank you for going backwards for me. But I want to also tell you about another study that's being done that was just done by Dr. Bart de Keyser from Prinses Maxima Center for Pediatric Cancer at Utrecht in the Netherlands. They looked at doing a comparison between I-123 MIBG and MFBG on standard SPECT CT and PET scanners. And they found that they detected a higher, equal, and lower number of soft tissue lesions, as shown here in the yellow. And on average, 2 more soft tissue lesions and a 6-point higher COPAN score were detected per patient using MFBG PET-CT. Anybody here had access to MFBG? I wish I did too, so my hand's not up for there. But it's coming, and I think it can be made in-house. So these are the new techniques that we're using. We're trying to change how we're using molecular imaging. And because of that, some of the clinicians are looking very closely at interacting with us. This is a paper from Barcelona, from the new Pediatric Cancer Center in Barcelona, which is an amazing cancer center. I'll show you a picture in 1 minute. And the oncologist there is Professor Jaime Mora, who basically studied neuroblastoma patients being treated with a monoclonal antibody, anti-GD2 monoclonal antibody for high-risk neuroblastoma who have a very poor overall survival. And they were treated with or without associated chemotherapy, but they showed good objective response. They had 62% of the 16 specimens that they looked at histopathologically in these patients treated with this antibody who showed persistent lesions on MIBG and maybe on FDG PET were fully mature neuroblastoma. So his paper highlighted the limitations of conventional imaging in the evaluation of this immunotherapy that is currently now being adopted at many centers treating patients with neuroblastoma. So we need to think about changing how we're going to image neuroblastoma. And this is the Barcelona Cancer Center. The reason I show that is this was built with 40,000 euros of donation money. Can you imagine? That would build a garage in Palo Alto. And all of these papers that I just showed you were discussed at a wonderful pediatric nuclear medicine meeting that's usually held every 3 years outside of Barcelona, organized by Dr. Isabel Roja. This was the 11th symposium, and there we all were at a wonderful dinner we had there. So the last thing is there's some new theories. So if we've heard about this a lot, the growth of theranostics, the growth of theranostic pairs. We know about some of them already that are being used mostly in adults, and I think these are coming to the pediatric world in the future, not here yet. With apologies to a couple people, to Hanahan and Weinberg, who published the initial hallmarks of cancer, and then I blatantly stole this from Dr. Rodney Hicks, but I have credit him there. When he gave a lecture, a virtual lecture at Stanford, he used the original Hallmarks of Cancer article. If you haven't read that, is required reading, and I'm happy to give you the reference for that at some point. And he added all of our theranostic pairs that we might be able to use, or the molecular imaging agents related to the molecular science that's looking at the genetic science of how this disease is working. And so we've got a lot of work ahead of us. So that brings me to what we're going to do next. So what we're going to do next is through the Society of Nuclear Medicine and the IAEA and 19 collaborative societies, including yours, we're going to take a global initiative look at neuroblastoma because it's a smaller disease entity and we know each other. We know each other from all over the world. We're starting with a survey that's based on part of the Lancet Oncology Commission that's already published 2 articles that relate to imaging and oncology, and under the guidance, help with Dr. Andrew Scott and IAEA. So we're looking to formulate this survey. We're still creating some of the specific questions that we want. We were going to limit it to neuroblastoma, but the theranostic questions are actually going to be about theranostics in pediatrics. I think it's a small group at the moment, but we're going to get that information. We're looking for regional country-based champions, and already since the Society of Nuclear Medicine meeting in June in Chicago, I've had many people volunteer to be champions. What it means to be a champion is that we're going to contact you to tell us who in your area actually treats children or images children. And we're looking at a comprehensive global assessment of this. We want this survey to go out to as many people as possible. We've identified 260 based places to start with. We can increase that by many more. We're going to determine the scope of the project. We're going to hypothesize that if we diagnose and identify response according to standard treatment, or we're going to figure out what standard treatment is globally, we're going to try to secure funding for an international clinical trial, the first of its kind as a truly international clinical trial in pediatrics. And we have a lot of interest from industry for this. And this will be a template project, because if we can do it in pediatrics, it can be done in much bigger studies in a global way so that we do it the same way for everybody. So lofty ambition, but that's what I hope is next. So this was a little different than what I usually present. I just say that everything old is new again. It really does fit in with your theme of going back to our roots. It always takes a village, and I'm here because of your kind invitation, but remember, everybody at home is working for me, including my staff, including the pediatric radiologists I work with, and including the wonderful nuclear medicine physicians at Stanford Adult Hospital. And there's my email there and my phone number. So thank you very much for your attention.
Thank you very much, Prof. Nadel. That was lovely. I think, if you don't mind, we'll leave the questions and move on to the next session.
Perfect.